I would like to offer you the following disclaimer. We are not about to replace prevention strategies that are inexpensive, safe, and readily available everywhere with expensive antiretroviral therapy. We would like to synergize with them. And so I remind you that we continue to advocate for education, changing behavior, harm reduction, and we continue to invest on new strategies and vaccines, hopefully one day a cure and an effective therapeutic or preventive vaccine. As it is today, existing strategies have failed to contain the global HIV pandemic, in fact, even the local HIV pandemic in many areas. So doing the same all over again is not working. We need to do something different. At the time, in 2006, these thoughts were rather provocative, if not controversial. I'm happy to tell you that since then, this thinking has become the norm. Is there a proof of concept that antiretroviral therapy can stop HIV transmission? The answer is yes, a resounding yes. In fact, a very successful yes. And that is derived from the experience of treating HIV-infected women who are pregnant. This is Canadian data that shows in Canada the number of women infected with HIV becoming pregnant in the first decade after the 1990 years. And you see here that early on, the number of children born with HIV infection was growing proportionally to the number of mothers that were infected. This is the number of mothers, these are the number of children. The rates of HIV transmission from mother to child were in the order of 30 to 50% in the early days of the epidemic. As many of you may remember, in 1996, myself and a number of others, we discovered the so-called highly active antiretroviral therapy, in other words, the so-called cocktail or HART. And conveniently enough, we brought it to the world at the 1996 Vancouver International AIDS Conference. Vancouver 1996 was where this new treatment was adopted internationally and certainly in Canada. And you see that following 1996, here in 1997, 98, 99, and 2000, we have a changing pattern. More women infected with HIV becoming pregnant, less children becoming HIV infected as of those pregnancies. In fact, I have updated that plot here, and the red illustrates the number of children born with HIV between 2000 and 2008. We have virtually eliminated vertical transmission of HIV through the use of HART. This is a meta-analysis published July of 2009 by Attia, Egger, and others, and basically shows that in the absence of antiretroviral therapy, there is a substantial likelihood of HIV transmission, as illustrated by these dots here, which is proportional to the viral load in the HIV-infected member of the couple, the index member of the couple. You see that this, although it decreases with the lowering viral loads, it only gets relatively low at 400 copies or less, yet it remains substantial, as illustrated here, about 0.2 per 100 person years. In the situation where we have people treated, these are untreated individuals, when we have people treated with antiretroviral therapy, as you see here, immediately the estimates go down very, very dramatically. And I have copied here the conclusion of the study for you, which says that studies of heterosexual discordant couples observe no transmission in patients treated with antiretroviral therapy and with viral load below 400 copies per ml. However, the data were compatible with one transmission per 79 persons years. So, this is to say, the confidence intervals are such that we cannot rule out the possibility that one infection can occur. But as you can see, the number of infections that would occur would be, even within those boundaries, rare indeed. Why is this phenomenon? Well, very simply, because when we looked at the effect of antiretroviral therapy at the populational level, this is not a clinical trial now, I'm talking a true population analysis of the effect of antiretroviral therapy, you see that antiretroviral therapy has a very dramatic effect. This is data from the province of British Columbia, where we have only one place where viral loads are done. So these are all the viral loads done in the province over a given period of time. Before individuals start antiretroviral therapy, you see their frequency distribution shifted around the 100,000 copies of virus load. And you see that as people start treatment, whether it's 6 months, 12 months, 18 months, 24 or 30 months, really what happens is there is a very dramatic shift so that the median viral load here is now undetectable, less than 50 copies per ml. We have rendered a large pool of highly infectious individuals into a small pool of infectious individuals. This would be your so typical treatment failures or non-compliers. And so to highlight the point, most of these people carry wild-type virus. Most of the resistant virus is actually found in this range, so that the biology of the disease works in our favor, because those individuals that have resistant virus have lower viral loads, and therefore they're less likely to transmit resistance. This is data that is now published in the European Journal of Infectious Diseases by my colleague Aranka Anema.
So the first point I want to make is that despite the fact that injection drug use represents is practiced by a very small segment of the population, it has huge public health impacts. And when we neglect the health of even a small slice of the population, we jeopardize the entire public health. And the Manif cohort 2000 provided us with, this was a recently published paper that made, I think, a very important point that does add important information to our view of drug treatment as HIV prevention. This study looked at both drug treatment participation and injection as predictors of poor adherence to HAART. And what was found is, that those who were abstinent, represented here by the green bars, were very similar to those who were in either buprenorphine treatment or methadone treatment and not injecting. However, those who were injecting and in buprenorphine treatment and methadone treatment had twice the rate of poor adherence. So the point is that it's not just being in treatment that protects people, it's being in treatment and responding to the treatment and reducing and eliminating injection practices. This has implications for the promotion of medication-assisted treatment as a harm reduction modality, which simply focuses on the distribution of the medication. This is a point that I believe strongly in, that we can't lose sight of the fact that addiction treatment requires both the availability and appropriate use of medication, as well as effective counseling strategies. And the final bar here is simply those individuals who continued to inject and were not in treatment. And again, related to my concern about drug treatment as a harm reduction strategy, I just want to say, even the use of the word substitution, I think we need to move beyond the phrase substitution treatment and refer to these treatments as medication-assisted treatments, because drug treatment is more than simply substitution. Effective treatments use safe and stable dosing, drug use is monitored, drug counseling is provided, and access to other services are also available. We have very little data on stimulant users and interventions that might reduce the risks associated with stimulant injection and non-injection. And there really have been no randomized controlled trials with HIV or HCV endpoints. Just to try to conclude here, I just want to remind all of us that drug use and treatment exists on a continuum, and most of the work that I've been reporting on now really represents this narrow slice of the drug-using population who have the most severe dependence upon primarily opiates and are in, and our studies have been focused on methadone and Suboxone treatment. But most of the drug users are not yet dependent, and I think we should all be focused on efforts to reduce risk and drug use among those individuals before they reach the most extreme conditions. And finally, we have evidence now that all of these approaches can be effective. Drug treatment, community outreach, harm reduction, and HIV care. And yet there are very few places where there's true integration of all of the elements of what are required for what I believe is public health, an effective public health strategy. So I think our future research needs to focus on ways to better integrate what we already have and what we know is or can be effective. Just a few summary comments, and I promise this is the last slide. Just to review what I've already said. IDUs are a small segment of the population, and yet a major part of HIV and particularly HCV infected populations. And when we neglect even a small portion of our population, we run the risk of having significant negative impacts on the entire public health. That research on opiate injectors, primarily using studies of methadone maintenance treatment, provide what's best viewed as a proof of concept that other drug treatments will also be effective in reducing HIV and HCV transmission. That we've seen selected expansion of methadone treatment, but primarily as harm reduction, and the coverage still remains very, very limited. There's a need for research on treatment approaches that focus on non-injection drug use. And we need to include HIV and HCV endpoints in earlier stages of drug treatment trials and medication development trials as well. It's a shame that we're only now testing buprenorphine and Suboxone as an HIV prevention intervention. We could have done this much earlier in smaller trials. And finally, that prevention messages need to begin prior to the initiation of drug use if we're going to have any impact on HCV transmission.
So first, let me speak for a few minutes about HIV infection and the effects of HIV on the central nervous system. We now recognize that about 30 to 50% of people infected with HIV have neurocognitive problems. Neurocognitive means that these are difficulties with memory, attention, processing of information, decision-making. Those are the kinds of abilities we are talking about when we speak of neurocognitive disturbances. And these are the kinds of disturbances that usually suggest that there is some underlying condition or disease of the brain. I'd like to talk about two conditions that may influence and worsen the nervous system complications of HIV. And the first of these is drug abuse. As I mentioned, I will be focusing on methamphetamine, which is a stimulant drug that is a serious problem in many parts of the United States, and which itself can cause a neural injury in high doses. However, we do see as well, I showed you before, these pictures of dendritic simplifications, that in the combined HIV meth group, people dying from both conditions, there is far more loss of neurons and neuron connections than in either case alone.
It is estimated that in our community, 30% of people infected with HIV don't know they are HIV status. In addition, 40% of new diagnoses of HIV infection are performed in advanced stages and sometimes in an irreversible situation. Late diagnosis of HIV is one of the most serious problems in AIDS today. One of the strategies to encourage people with risky sexual practices to know their situation is the promotion of HIV testing. Publicity campaigns have been used for this purpose. She doesn't know she's seropositive, and you? In summary, we wanted to offer an alternative to the general population with risk practices who, by different reasons, don't want to go to their family doctor and who can or want to pay €5. 6 months later, at the end of August, the program of rapid HIV tests in pharmacies has exceeded expectations. Almost 2,000 analyses were performed, twice the expected. Men were 70%, women 30%, median age 36 years, and 10% were foreigners, 10%. The customers choose a pharmacy mainly by 3 reasons. The first was rapidity, it's 15 minutes only. The second, anonymity, is 15%, but we think that it is a bit more. And finally, accessibility. Timetable, pharmacies are open all day and they are geographically distributed. For the pharmacies, the experience is very motivating and strengthens their role as health advisors in the community. We are presenting the preliminary report of this new experience. The final evaluation of the program will be on March 2010. Meanwhile, I have to say that the implementation of HIV rapid testing in pharmacies is an excellent, innovative, effective, and useful alternative to detect new HIV infections, although there are areas of improvement.
Alors le sida, c'est quoi? En 81, on découvre une nouvelle épidémie qui deviendra l'épidémie VIH. Et je vous rappelle qu'en 81, pour nous en France, ça a été un changement politique. Ça a été dans les premières décisions politiques qui ont été prises, sans vouloir faire de débat politique, l'abolition de la peine de mort et l'abolition du délit d'être homosexuel. Bon, les plus jeunes d'entre nous ne se souviennent pas qu'il était interdit d'être homosexuel et de l'afficher. Et on a eu en même temps la communauté homosexuelle qui s'est organisée et qui a dû faire face à cette nouvelle stigmatisation qui était la maladie VIH. Et à l'époque, c'était bien des personnes qui étaient repérées. On parlait des 4 H, si vous vous souvenez. C'était les héroïnomanes, les homosexuels, les hémophiles et les haïtiens. L'hépatite C et le VIH sont 2 épidémies aux trajectoires sociales différentes. On est passé des 4 H à aujourd'hui une épidémie qui se centre sur les hétérosexuels, alors que du côté de l'hépatite C, on est passé d'une épidémie des hétérosexuels et des transfusés à une épidémie vers les usagers de drogue. Les flèches ne sont pas dans le bon sens, je vous l'accorde. C'était pour voir ceux qui suivaient. Ça, c'est important parce que ça va nous expliquer pourquoi socialement, les 2 épidémies dans leur représentation sociale ne sont pas du tout les mêmes. Ce que nous avons appris du VIH, c'est qu'aucun pays n'est à l'abri de l'épidémie. Nous avons appris à écouter, à parler aux patients et réciproquement. Le fait d'avoir des gens jeunes qui se retrouvent en situation de mortalité nous a fait revisiter les soins palliatifs et l'accompagnement, qui étaient pour nous essentiellement centrés pour les cancéreux et les personnes âgées. Il y a eu une urgence à ce moment-là à modifier nos pratiques. Et les services qui se sont confrontés au VIH ont accepté de modifier leurs pratiques, accepté de s'asseoir à côté des patients qui étaient jeunes, qui avaient peur de mourir. Et on était dans des situations de guerre infectiologique qui ont modifié tout le monde. On a créé les centres de dépistage anonymes et gratuits. C'est assez intéressant parce qu'on est venu tout doucement changer de venir repérer si j'étais dans un groupe à risque et on est devenu des centres capables de venir interroger sur les comportements à risque. Et aujourd'hui, on a toujours cette différence. On fait plus de 8 millions de tests du sida par an en France. On les répète. On est dans quelque chose de dynamique. On vient interroger ces comportements alors qu'on vient simplement regarder si on est porteur d'une hépatite B ou d'une hépatite C. On est là dans quelque chose de statique. Il va nous falloir inventer une dynamique aussi sur les hépatites. C'est très important, car aujourd'hui, quand on interroge les centres de dépistage anonymes et gratuits, on est aussi dans la même situation avec les centres d'addictologie. D'un côté, une infection dynamique où on interroge sur les comportements, de l'autre, on est déjà content quand on a pu faire un test de l'hépatite B ou de l'hépatite C. On a aussi mis en vente libre des seringues, ce qui n'a pas été un débat politique facile. On a validé, à cause de l'épidémie du sida, les concepts de substitution. On a inventé la réduction des risques. Après les années pilules, on a redécouvert le préservatif et la place qu'il pouvait en prendre dans les relations sexuelles. On a fait des campagnes de prévention en prime time à la télévision. On a créé des fonds d'indemnisation pour les transfusés dans les premières années 80, où les gens ont été indemnisés sur le simple fait d'avoir été transfusés. On a créé une journée mondiale de lutte contre le sida le 1er décembre. On a inventé les stéribox. On a créé les concepts d'appartements thérapeutiques qui étaient une révolution culturelle, de pouvoir se soigner, d'être accompagné, d'avoir un statut social via une maladie. On a dépisté et mis en place des traitements en prison. On a développé des solidarités nord-sud. On est prêt à payer une taxe quand on prend l'avion pour que les traitements puissent être accessibles en Afrique. On a cédé des brevets du côté de l'industrie pharmaceutique vers des pays en voie de développement. On a créé l'ONU-SIDA, partant du principe, pour avoir rencontré les gens de l'ONU à plusieurs reprises, qu'être atteint de sida était une privation des libertés individuelles. C'était fondamental de reconnaître ça pour les pays en voie de développement. En France, on a créé l'Agence nationale de recherche sur le sida pour avoir une recherche d'État public. On a créé des réseaux, on a créé des corévies. On a modifié nos prises en charge sociales. On a créé la pension d'adulte handicapé qu'on a revue au titre du sida. On a fait bouger le système d'assurabilité avec les premiers rapports Bellorget pour dire qu'un patient VIH traité ne doit pas être stigmatisé, doit pouvoir accéder à des prêts bancaires. Et ça a modifié complètement le rapport à l'assurabilité pour aussi toutes les maladies chroniques comme d'autres cancers. On a modifié les représentations des soignants et bien sûr de la population générale. On disait pour rire, on a trouvé un traitement pour le sida dans les hôpitaux, c'est le saumon et les crêpes, c'est les seules choses qui passent sous les portes. Aujourd'hui, ça reste une boutade, on ouvre les portes et on parle à nos malades, ils nous font beaucoup moins peur. On a une ALD pour le VIH, on a un SIDAction et, chose très importante, on a développé du matériel à usage unique. Ça peut nous sembler anecdotique, mais des millions de contaminations ont encore lieu chaque année parce que les seringues ne sont pas à usage unique dans plein de pays d'Afrique.